Hi, Mike Gibson and Jaya Chandrasekhar coming to you live from SCAI 2016. Jaya, talk to us about sex differences and outcomes among people undergoing TAVR.
Well, thank you very much for inviting us to this session. So this was an analysis out of the STS ACC TVT Registry, and the senior author on this report is Roxana Moran. As you know, she's very interested in sex-related differences in both PCI and now transcatheter aortic valve replacement. So this was a snapshot for a 2-year period, so 2012 to 2014, 348 US sites that have to contribute data mandatorily into the TVT registry, and this is for reimbursement purposes. So we had a total of 23,652 patients, and as with other studies, as we've seen from other studies, equal representation of men and women.
A little different than ACS, where we tend to get 1/4 women, 3/4 men.
Exactly.
But this is done in a way where you capture everybody as part of a registry.
Absolutely.
A little different than trials.
Yes,
Yeah.
and you know, you say the risk profiles are different from PCI, so that's what we were interested in. We've seen other comparatively smaller analyses showing, you know, women have more procedural complications, yet at 1 year survival is superior to men. So why is that really? And when we analyzed the differences in baseline characteristics, women were somewhat older than men, so 83 years versus 82 years for men. The STS score was a little bit higher, so 9% in women, 8% in men, and there were a lot of risk factors that had a lower prevalence in women, so less diabetes, less prior revascularization, PCI or bypass surgery, less coronary artery disease, so less triple vessel disease, atrial fibrillation was lower, peripheral artery disease was lower. So that's interesting and something to bear in mind as we go on with this conversation. So 26%, I think, in women, peripheral artery disease, 36% in men. And we thought, oh, are women all just lower risk? So there's other things that swing things the other way around. So
any
other
quantitation of the size of their, you know, iliacs or femorals or
right,
anything?
so we don't have the femoral artery diameter as such, but when you use the sheet size, the mean sheet size, it's
smaller.
22 in women, 22 French, 24 French in men.
Yes.
So of course this is not quite a contemporary analysis. These are not contemporary devices where we talk about 18 French or lower, smaller sheet sizes. So this is, you know, older generation devices. Most of these are balloon expandable valves. And interestingly, women had a greater prevalence of porcelain aorta compared to men. And although the left ventricular ejection fraction is higher in women, so I think it was about 57% in women, 51% in men, yet women had more moderate or severe mitral valve regurgitation, which has not been seen or shown in other studies. So that's something interesting to explore.
So a little better
bit
systolic
further.
function, but how about diastolic dysfunction?
We don't have those data, and I think perhaps it's
which
being
tends
looked
to be
at.
more in women, and
Exactly.
may explain some of the mitral regurgitation as well.
Women have more hypertrophy, less dilatation, and you know, perhaps earlier regression after TAVI. So all these things are going to be important to look at.
An extent of CAD?
So yes, women had less prior PCI, but also a big difference in prior bypass surgery, 46% in men, 16% in women.
Wow.
So that's a huge difference.
Huge
and of course, if you've had prior cardiac surgery, you know, your risk profile for future surgery is going to be very, very different.
Absolutely.
Yeah.
And then when you look at long-term outcomes, what did you see?
So, you know, before we even looked at the long-term outcomes, we compared the procedural complications.
Yes, sure.
So we talked about the sheet size, 22 French in women, 24 in men, but very interestingly, women in this cohort during the study period had more TAVR via non-transfemoral approach rather than transfemoral approach. So, you know, I talked about the peripheral artery disease, 25 or 26% in women, 36 in men, yet more women than men had non-transfemoral TAVI.
Why is that?
And I think it's something to do with the definitions as well. So when we talk about PAD in the TVT registry, it doesn't account for femoral size. It's claudication, amputation, you know, non-invasive ischemia.
So they could have a clean artery, but it's just too small for the approach.
For the then available devices. And so women had more transapical, transaortic access, And in terms of procedural complications and need for conversion to surgery, yes, overall the rates were very, very low. So about 1.7% overall. Yet the frequency of requiring conversion was higher in women compared to men. In men, it was under 1%. So women had more ventricular rupture, annulus rupture, aortic dissection, coronary artery obstruction, nearly a 5-fold higher odds of coronary artery obstruction in this time period with these devices compared to men. And men, on the other hand, had more embolization of devices into the left ventricle. Perhaps that's what we see with devices that we're deploying or have been deploying so far. And in terms of other procedural complications, so the usual culprits, vascular complications and major bleeding, yes, women had nearly doubled the rate of vascular complications. A trend for more bleeding when you adjust for all the confounders, not quite significant. And the same thing with NACE, so a trend for greater NACE in women than men. So, so far it looks like we used bigger devices, non-transfemoral access, not quite contemporary devices, and women had more complications. Yet, when you look at in-hospital survival, it's similar to men.
Interesting.
And maybe it's because of those lower risks we talked about, less coronary artery disease, a higher ejection fraction. And then when you go on to 1 year, women do better than men. So survival is 24.5%, the mortality is 24.5% in men, 21% in women. And when you look at composites with death or stroke, death or MI, similarly, women do better than men. And we also looked at bleeding. So of course, bleeding beyond discharge can be a reflection of antithrombotic therapies. We don't quite know what the best regimen is in TAVR patients. And recently there's been a discussion about possible subclinical valve thrombosis. So all of those things are going to be important. We've been getting away with dual antiplatelet therapy maybe for 6 months. And now if we're going to be talking about, anticoagulant therapy in these patients, at the minute we don't show differences in bleeding at 1 year when you look at claims data. But with evolving therapies, evolving practice, maybe all of that will change.
And with a more careful look, we might see some differences that don't show up in claims data.
Yet I think, what's really important beyond this report will be to repeat a similar analysis with
newer technology,
newer devices, smaller devices, and see if these differences in vascular complications are now attenuated. It cancels out. And then maybe women will do better even earlier on than men.
With the smaller devices.
With smaller devices.
Complications. And that may translate into better long-term outcomes as well.
And then we're talking about intermediate risk and lower risk patients. So it should allow more women perhaps to be treated with TAVR than needing surgery. We don't know. We'll have to see.
Well, very careful look at a lot of data. Congratulations. Thanks for sharing it with us here today.
Thank you. Thanks for inviting us.
Yes, and thanks to all of you for joining us here from SCAI 2016.